HBCM Lectures on Musicians' Hand Dystonia. Lecture 1, Peripheral Factor Model, Part 2. Model Scenarios, Discussion, Conclusions. Content. The model presents 6 generic scenarios, each reflecting distinct model parameter configurations. 2 scenarios describe parameter configurations not at risk of musicians' hand dystonia. A third scenario models hands anatomically unfit for professional playing. 3 further scenarios model factor configurations that may predispose to musicians' hand dystonia. Discussed are the implications of the peripheral factor model for musicians' hand dystonia treatment, including hypotheses that might help explain the unpredictability of current treatment results. Scenarios: playing with hand factors. At all time, throughout life, a musician faces a fundamental test. Are the movements required to play the instrument, given the occupational load, part of the feasible movements? Depending on the outcome of this test, different model scenarios result. The fundamental test forms the heart of the model, and therefore the test criterion needs to be critically discussed. Within the model, the complete criterion is: are the required playing movements at the voluntary performance level fully realizable with normal motions and forces? Unfortunately, normal motions and forces is a qualitative criterion and therefore open to interpretations, because a standard for normal playing motions and forces cannot be exactly defined. Moreover, the determination is by biomechanical criteria that are task and instrument specific, and therefore cannot simply be generally defined either. The basic methods of biomechanical diagnostics will be discussed in the section Treatment. These methods will be exemplified in the case studies presented in the follow-up lectures. Scenario 1. Unlimited hands. Unlimited is here defined as meaning that all required movements can be realized at a voluntary performance level with normal motions and forces. In that case, there are no instrument technical playing problems. The musician develops a satisfactory playing technique and enters a safe state. In this model, a playing state is considered safe when the playing technique, once fully established, becomes practice invariant. That means that further practice will not fundamentally change the playing technique anymore, and also that there is no need for changes because the technique suffices for all voluntary repertoire. However, throughout life, this safe state is conditioned by an event loop, since factors can change. If factor changes lead to failure of the fundamental test, the musician is not in a safe state anymore and enters another scenario. The scenarios in which not all required playing movements are feasible with normal motions or forces will be called constrained. When there are required movements that cannot be realized with normal motions and forces, there is an instrument technical playing problem. This does not necessarily mean that the instrument cannot be played. However, it means that some form of functional compensation will be necessary to realize the playing tasks. Functional compensation in playing motions consists of the recruitment of extra normal function, for instance, from other joints and muscles than normal. This may include changes in motion trajectories, muscle synergies and forces, contact forces, posture, and others. In terms of diagnostics, movement kinematics can be visually observed and recorded, for instance by video, and in principle also highly accurately quantified by motion tracking. Therefore, compensatory kinematics can be well observed. However, forces are invisible. Therefore, the detection of enhanced forces between movements that are kinematically not significantly different is much more problematic. When is compensation functionally stable? In this model, functional compensation is stable when two conditions are satisfied. Firstly, the compensation must be effective, meaning that the compensation must produce a playing result acceptable to both the musician and the audience. Secondly, the short and especially long-term effort to perform the compensated motions must be within physiological capabilities. Scenario 2 considers an over-constrained hand. By definition, in an over-constrained hand, too many required playing movements are not feasible. The model envisages a practice loop to develop effective compensations. However, these fail to develop. For lack of progress, the subject eventually abandons playing the instrument. This may be the case in a certain percentage of children that start playing an instrument. They progress to a certain level and then stagnate in developing more proficient playing techniques and eventually quit playing. Scenario 3. The feasibly constrained hand. In the feasibly constrained hand, the musician develops effective compensations after practice. When these compensated movements are physiologically sustainable, the musician enters a safe state with adequate practice-invariant playing motions. In the safe state, the musician throughout his life remains in an event loop for factor changes. However, to the degree that the hands are already compensating, they are more vulnerable for factor changes, meaning that small changes may have disproportionate consequences. For example, a voluntary factor change in occupational load, such as changing to technically more demanding repertoire, may lead to additional instrument-technical playing problems in the fundamental test. This may drive the development of additional compensations in the attempt to upgrade the playing technique, which might or might not be effective and physiologically feasible. In summary, while feasibly constrained hands may achieve a safe state, this would take more practice, possibly significantly more practice, than if the hands would be unlimited. Indeed, developing effective and sustainable movement compensations is likely a significantly more complicated learning process than learning to play with unlimited hands. A safe but compensated technique is also more vulnerable to factor changes. This means that small factor changes may have disproportionate consequences, such as playing movements exceeding physiological limits, as modeled in the next scenario. Scenario 4. How can hand factors predispose to task-specific musicians' hand dystonia? Consider a musician who developed an effective compensated playing technique in a practice loop called Loop 1. However, in the long run, these compensated motions exceed the physiological capacities of some muscles. The CNS receives feedback about this and will try to modify the playing motions to bring them within physiological capabilities. That means increasing the compensations. So now two compensation loops exist. One loop that has driven the development of compensations to resolve the instrument technical playing problems, and a second loop that drives the development of further compensations for physiological reasons unrelated to the instrument technical playing difficulties. However, if the latter compensations systematically fail to bring the playing motions within the long-term physiological limits, A safe state in which the playing technique becomes practice invariant will never be reached. A non-ending loop of ever-increasing compensation results. When would control dysfunction develop in this model? By hypothesis, when overcompensations start to produce ineffective playing movements. For instance, when overcompensated motor patterns start involving antagonists to intended movement. Then the effectivity test fails and the musician becomes aware of playing control problems. In summary, effective playing movements are modified in a non-ending compensation loop too, because the long-term physiological feasibility test never gets satisfied. Eventually, overcompensation causes the playing movements to become ineffective, which is the onset of symptoms. The model contains competing processes at different timescales, which in the following will be detailed. In the model, compensation processes caused by two unrelated objective functions are in competition at different timescales. One objective function, the effectivity objective, aims to enhance playing motions in order to resolve instrument technical playing problems. This objective function is voluntary driven, subject to teaching and the individual practice methods. The second objective function, the sustainability objective, aims to modify the resulting movements into physiologically sustainable motions. This objective function is subconscious, CNS-driven, and operates on long term. The sustainability objective may by further compensations reduce functional enhancements produced by the effectivity compensation loop. This may lead to a situation in which instrument technical playing problems remain unresolved and therefore become attractors for repetitive and stereotypical practice, driving these compensation loops. An example of a voluntary aspect in such a process would be the perfectionistic practice of minor but irresolvable playing problems. This schematic models the interactions of the effectivity and sustainability objective functions. From a practice loop emerge playing movements that solve instrument technical playing problems caused by failing the fundamental test. These playing movements must be sustainable or long-term. If not, the CNS will modify them. When thereafter these playing motions are still functioning, the musician may enter a safe state. Otherwise, the effectivity practice loop continues. This model warns that over-practicing may deteriorate instead of enhance playing technique, since excessive practice will make the sustainability objective more dominant. Therefore, when effective, even if not perfect, playing motions exist at a limit of sustainability, excessive practice may cause their elimination by the sustainability criterion. Once eliminated, these motions may be replaced by likely less effective motions. In this way, over-practice may deteriorate instead of enrich playing technique. Of particular interest, also for prevention, is the moment of onset of symptoms. The possibility of overcompensations resulting in control problems requires an additional test in the effectivity practice loop. Indeed, what causes a lack of movement effectivity? Is it a playing problem caused by inadequate technique, or is it discontrol? Since both are dysfunctions, at the very onset of symptoms, the distinction between a persistent technical playing problem and the beginnings of discontrol may be impossible to make. Therefore, when discontrol resulting from overcompensations starts reducing playing effectivity, the musician will be inclined to interpret this as an instrument technical playing problem requiring more practice. The need for such practice may be critical with performance pressures, such as preparation for a concert. However, in this practice, the musician would start to compensate for discontrol, i.e. for motor patterns already dysfunctionally overcompensated. Such practice, when sustained, may then, in a short period of time, drive the motor patterns into severe overcompensations, resulting in gross control dysfunction when attempting to play the instrument technically problematic musical repertoire. In this model, practicing dystonic motions means compensating for already dysfunctional overcompensations. With such discontrol, there is no proportionality anymore between the intended and the actual movements, and without this proportionality, no effective learning is possible. Therefore, practicing dystonic motions in the model's effectivity practice loop will not resolve but likely aggravate symptoms. Trigger events preceding the development of symptoms are frequently reported by musicians with hand dystonia. Examples are excessive practice for a concert, new technically demanding repertoire, changes in playing technique, new instrument with differences in geometry or action of the hand interface, small trauma, and others. These events may interfere in the model at different levels. Trigger events may challenge movement sustainability by increasing physiological load, for instance by increasing practice time and concert programs. However, trigger factors may also be decreases in physiological limits, for instance by systemic diseases. As an example, at a hand clinic for musicians in Rotterdam, one guitarist had developed right hand dystonia in the initial stages of multiple sclerosis. Playing technically more difficult repertoire may increase or create conflicts in the fundamental limitation test, and therefore aggravate instrument technical playing problems in the effectivity compensation loop. Trauma may cause physical limitations and other factors that increase the conflict in the fundamental limitation test. Changes in the hand interface may also aggravate the conflict. For instance, a slightly larger new violin for a small-handed violin player. In summary, trigger factors typically negatively disturb an existing equilibrium in this compensation model. With the physiological sustainability condition, the model has a fundamental overuse component. Therefore, task-specific musicians' hand dystonia is in competition with other forms of overuse, such as painful inflammatory-based overuse as tendinitis. To complete a model, the possibility of other overuse manifestations must be included. The musician's hand dystonia model so far has 3 exits. When practice fails to produce sufficiently effective playing movements, the subject eventually abandons playing. When no compensations are needed or when compensated movements are effective and sustainable, the musician enters a safe state. When the physiological sustainability condition remains unsatisfied at long term, the compensation loops may produce dysfunctional overcompensations diagnosed as dystonia. However, failure of the sustainability condition may produce other forms of overuse such as tendinitis. By hypothesis, the forces at play in the compensation loops resulting in dystonia remain beneath those necessary to produce inflammatory overuse. However, these outcomes are in competition, and in principle, dystonic symptoms and inflammatory overuse may coincide with unpredictable implications. For instance, inflammatory overuse may result in compensatory behavior that helps drive the dystonia-generating compensation loops. On the other hand, a rest period to heal a tendinitis might boost a physiological capacity suffering from acute exhaustion and therefore may actually help preventing the development of dystonic overcompensations. Scenario 4 in the above considered healthy hands with limitations relative to the playing tasks. Scenario 5 considered hands with specific defects in the movement apparatus, which will be called under-constrained hands. By definition, under-constrained hands have neuromusculoskeletal defects that affect the mechanical controllability of individual joints or joint chains. Motion control is obtained by muscles as active elements, but also by passive elements such as joint ligaments and tendinous mechanisms. Defects in these controlling elements, active or passive alike, will structurally decrease the controllability of the movement apparatus. For example, a defective joint ligament may result in an unstable joint. In mechanical terms, in this joint then movement directions have become possible for the control of which the muscle system is not optimized. By proprioceptive feedback, the CNS is informed about such instabilities and will try to adapt muscle use to increase control stability. The need to increase system controllability then forms an objective function that drives control compensations for reasons unrelated to the playing tasks. In under-constrained hands, two independent objective functions are in competition. One is optimizing control stability. If the factors are subclinical, this optimization is subconscious, CNS controlled. If the factors are clinically diagnosed, optimizing control is the objective of treatment. The other objective function is optimizing performance, which is a voluntary objective. By hypothesis, in the CNS, the optimizing of control stability has priority over optimizing the playing task. Consequently, the compensations for optimizing control are boundary conditions for the compensations in playing task optimization. Task execution problems or discontrol may emerge when, for example, control stability compensations negatively modulate playing motions. Clearly, for musicians' hand dystonia, the real risk factors are subclinical, i.e. obscure defects. Clinically diagnosed factors and their consequences will be clinically treated. This schematic may model the situation. A musculoskeletal defect causes the controllability problem. The CNS develops compensations to enhance controllability. The outcome of this compensation loop forms a boundary condition for optimization of the playing motions given the defect and possibly other peripheral limitations. Obviously, the defect compensation loop may negatively condition the playing movement compensation loop, increasing the likelihood of a dysfunctional outcome. The dysfunctional outcomes may be dystonic symptoms, or irresolvable technical playing problems and/or other forms of overuse causing abandonment of playing. In such a compromised system, a safe playing state may not be possible. Note that defects may be subclinical, innocuous in daily life, while yet active in instrumental playing. The last scenario in the lecture investigates yet another category of peripheral factors, namely, factors that influence playing motions by causing energy losses. By definition, dynamic constraints are energy losses during motion in excess of the normal energy losses. Such energy losses are caused by increased gliding resistance or stiffness in tissues deforming during motion. Prime causes are internal scar tissue resulting from trauma or surgery. Examples are muscles and tendons moving through a scar bed, or stiffness in the tissues moving and deforming with joint motions such as joint capsules, joint ligaments, and the tissue layers including skin covering joints. By definition, dynamic constraints do not strictly limit motion. Their impact consists of the excess forces and energy losses they cause during motions. Mechanically, there are three causes of excess forces and energy losses. First, elastic force is proportional, not necessarily linear, to the increased stiffness and the degree of stretching of the stiffer tissues. Second, increased friction between moving parts, such as muscles and tendons, and their environment. Third, the tissues deform or move in a fluid or wet environment which has viscous properties. Therefore, energy losses occur proportional to this viscosity and the motion or deformation speed of the tissues, since viscosity energy losses are a function of speed. As an example, consider finger tendons dragging loose adhesions through a synovial environment. Excess forces and energy losses occur from stretching these loose adhesions, from increased friction, and from moving the tendons and adhering tissues in a viscous environment. How can dynamic constraints contribute to developing musicians' hand dystonia or other forms of dysfunction? In repetitive fast motions, when optimal playing motions are not sustainable due to these energy losses, the CNS will subconsciously modify the playing motions to minimize energy expenditure. There are then two competing objective functions: optimizing playing motions versus developing playing motions that minimize energy losses. In the long run, and also proportional to the occupational load, minimizing energy expenditure will dominate. The only way to achieve this is by developing movements that minimize the movements and deformations of the less compliant tissues. The resulting motions may not be optimal anymore in solving the playing tasks, so that instrument technical playing problems result that may drive the playing optimization loop into developing further movement compensations and possibly overcompensations. The processes generated by dynamic constraints are here schematized. Consider the example of a musician with an adequate playing technique having an accident that heals with some slight residual stiffness. Then the original playing motions might not pass the physiological sustainability condition anymore. The CNS then develops playing motions minimizing the deformation of the stiffer tissues. These movement compensations are the input for further compensations for physiological reasons that might become active because of the movement changes. The resulting motions then must pass the effectivity test. If this test fails, then movement enhancement by practice is necessary. The result may be a non-ending loop of compensations, because all playing solutions fail either the physiological sustainability or effectivity conditions, so that the safe state is never reached. Eventually, overcompensations create discontrol. This situation would be further aggravated if there were pre-existing instrument technical playing problems. This scenario is identical to scenario 4, but the energy losses due to the less compliant soft tissues initiate and dominate the compensation processes, which could be diagnostically established. Therefore, dynamic constraints are part of the physiological sustainability condition and, when present, may dominate this condition. References. Dynamic constraints as possible predisposing factors in task-specific musicians' hand dystonia were already discussed in a 1997 publication. Since then, the author's hand lab has identified such factors in 3 cases, with different overuse outcomes, demonstrating that musicians' hand dystonia is in competition with other forms of overuse. One case was task-specific dystonia. One case presented with what seemed to be index extensor dysfunction by fatigue, and in one case a dynamic constraint at the wrist extensors was associated with severe painful task posture related overuse in the shoulder. The latter case was published in Clinical Rheumatology, see reference. The first 2 cases will be discussed in future HBCM lectures. A brief discussion of the model. The model here presented would explain key features of task-specific musicians' hand dystonia. Task specificity, since the compensation loops are driven by task-specific problems. Since the symptoms are by model hypothesis caused by task-related movement control overcompensations, the control should be normal in unrelated tasks. Late onset of symptoms. This is seemingly a general characteristic of musicians' hand dystonia. However, in this model, the incubation period would actually be scenario dependent. Scenario 4 might indeed have a long incubation period, among others because it requires a fairly narrow set of factors. This is because the model has different exits to prevent dystonia development. First, if no effective playing movements can be developed, playing is abandoned. Second, a movement effectivity conflict can be avoided by volition, notably by selecting repertoire that does not cause insurmountable instrument technical playing problems. Possibly, or even likely, many musicians' hand dystonias are being avoided by musicians avoiding problematic instrument technical repertoire. The musicians that remain in a dystonia-generating scenario must have playing problems within a certain bandwidth, not so severe so as to abandon playing, and allowing for sufficient playing effectivity to motivate keeping practicing, while only in the long run the sustainability criterion grinds its way through the task-specific motor control patterns, possibly only generating dysfunction after a trigger event. However, in the scenarios 5 and 6, which involve sequela of trauma leading to additional, highly dominant objective functions competing with playing motions, the incubation time to the emergence of symptoms may be much shorter. However, the incubation time should then be measured from the moment of trauma or of the resumption of playing thereafter, and not from the moment of commencing playing the instrument as a child. Painless, since the dysfunction is in acquired motor patterns and not in the development of inflammatory overuse. Generally, the forces in the development of musicians' hand dystonia should remain smaller than the forces needed to develop inflammatory overuse. However, both are forms of overuse, and therefore musicians' hand dystonia and inflammatory overuse might co-occur, or one might even facilitate the development of the other. Predisposing individual factors have been discussed. Hand instrument specificity, see next slide. Trigger events have been discussed. Rest does not help, as it will not change acquired overcompensated motor control patterns. Resistant to treatment, see next section on treatment. Task-specific musicians' hand dystonia could occur without CNS predispositions, see further applicability of the model. The musicians' hand dystonia statistics of the hand clinic in Rotterdam are consistent with the peripheral factor model. The hands that perform the most demanding tasks are most affected. The right hand in keyboard playing, left hand in string instruments. However, the 4:1 left-right ratio in the flutist needs to be explained, as well as the high incidence of right hand dystonia in the classical guitarist, see next slide. The competition between inflammatory overuse and musicians' hand dystonia was demonstrated in classical guitarists. Guitarists' left hands were more prone to inflammatory overuse than dystonia, while in right hands the incidence of inflammatory overuse was rare as compared to dystonia. For hypotheses about the prevalence of musicians' hand dystonia in the flutist and guitarist, the reader is referred to section 3.5 in the discussion in the publication of this model. What would be the significance of the peripheral factor musicians' hand dystonia model for treatment? First, the model limitations and the populations to which the peripheral factor musicians' hand dystonia model would apply should be discussed. The model is task-specific and centers on the assumption that musicians' hand dystonia can develop without CNS predispositions. The likelihood that the CNS is normal would be proportional to the task specificity. The more task-specific the symptoms, the more likely the model would apply. In the cases without significant CNS causes, if peripheral factors that cause functional task incompatibilities can be correctly identified and successfully eliminated, it should be possible to decompensate and retrain the hand to the golden standard of normalcy as defined above. Moreover, since causes of playing problems would have been removed, the outcome might even be a hand with improved playing capabilities. Could the peripheral factor model be extrapolated to other forms of task-specific dystonia? By definition, not to dystonias where symptoms are not task-specific. In writer's cramp, one could expect that the model applies in some cases. However, because writer's cramp recruits unselected from the world population, one might expect more causally involved CNS factors, for instance tremor, in which the model does not apply. Treatment in the peripheral factor model would consist of 3 steps. First and crucial, the validation of the fundamental test. Are the required movements within the feasible movements given the level of the repertoire? This requires the analysis of peripheral factors, hand-instrument interface mechanics, ergonomics, and behavioral factors. Second, crucial for success, to what degree can the conflict between required and feasible movements be reduced? Any such reduction would enhance the likelihood of success of step 3. Third, decompensate the discontrolled motor patterns and retrain the playing movements with possibly voluntary behavior changes in repertoire, practice methods, and workload. This schematic visualizes the treatment options. The aim of treatment is first to eliminate the fundamental conflict, because then the need for movement compensations disappears entirely. Nothing would then prevent developing a safe playing state. To resolve the fundamental conflict, clinical factors can be eliminated, hand factors can be eliminated, the hand-instrument interface can be adapted, and behavior can be modified. However, even after eliminating the fundamental conflict, the dysfunctional motor patterns would remain, since they are acquired by a learning process. Therefore, a safe state can only be reached after decompensation of the dysfunctional overcompensations, which would likely have to include retraining a playing technique. What happens in the model when the fundamental conflict cannot be fully eliminated? Then the need for compensations remains, and the path to a safe state becomes ever more complicated. Indeed, how to measure or ascertain that the factor changes that were possible have reduced the conflict sufficiently so that effective and physiologically sustainable movements have been produced after decompensation and retraining. By the same argument, if no factor changes are made, the likelihood of achieving a safe state by mere decompensation and retraining would be minimal. Indeed, in like circumstances, like results would likely emerge from the compensation loops, especially since these compensations have already been previously developed. Therefore, this model predicts that if a task-specific dystonia would be overcome without changes in instrument and hand factors, firstly, that the fundamental conflict would likely be mild, and secondly, that there would have to be significant changes in behavior, repertoire, playing load, practice habits, playing technique, and others. This being said, depending on the factors in the fundamental conflict, changes in behavior might be sufficient to avoid task-specific hand dystonia. For instance, when instruction or self-volition enforces a playing technique model that suppresses necessary compensatory motions. Physiological capabilities in playing may be exceeded, while a playing technique more attuned to the hand limitations would not do so. A word about biomechanical diagnostics. The aim of biomechanical diagnostics is to evaluate whether, or to what degree, the required playing movements are feasible. These diagnostics consist of three parts. First, hand factor detection, including anatomical limitations as quantitative as possible. Second, the analysis of dystonic motions to detect the underlying compensations. Neurologically, dystonic playing motions are generally considered mere dysfunction. But biomechanically, there is often considerable residual function present in these motions indicative of the preceding compensations. Third, using biomechanical models as a basis, it is evaluated whether the hand factors and the compensations that were detected in the motion analysis are mechanically consistently associated. If not, there is a suspicion of yet undetected factors, and more profound checks of hand factors, anamnesis and others must be conducted. The case studies in the follow-up lectures will illustrate this process. The main biomechanical model used to associate factors and compensations is knowledge about the transformation of muscle length changes in motions, which in multi-articular systems such as fingers and hands is not straightforward and can only be properly described mathematically. These basic models were already published in the 90s but remain essential in these diagnostics. Listed here are publications of biomechanical models used in biomechanical diagnostics. Note that not all models have yet been published. Peripheral factor surgery. In selected cases, anatomical limitations detrimental to playing motions could be surgically removed with the prospect of full recovery from task-specific musician's hand dystonia after decompensation and retraining. However, surgery also introduces internal scar tissue that needs proper primary rehabilitation and also long-term management to avoid scenario 6 becoming active. Therefore, such surgery requires a specialized rehabilitative setting. How does the peripheral factor model relate to current treatments? The fundamental difference is that generally in musician's hand dystonia, no peripheral factors are systematically biomechanically investigated or modified. Treatment then consists of specific procedures for decompensation and retraining, possibly including symptom reduction by medications such as Botox. However, in individual cases, instrument interfaces have been adapted, including the development of external positioning devices and functional ergonomic aids, also by the musicians themselves. Characteristic of any current therapy for musician's hand dystonia is the unpredictability of results. From point of view of the model, some hypothetical observations can be made. Firstly, when the fundamental conflict is sufficiently severe, and when the factors causing it are not addressed, no therapy might exist that produces symptomless playing at a workload preceding the onset of symptoms. Indeed, even after decompensation and retraining, the need for compensation for the factors causing the fundamental conflict remains, and with it the likelihood of recurrence of symptoms. In the case of mild factors that are not addressed, behavioral changes might lead to resumption of playing after decompensation. However, only a subset of the playing activity's workload repertoire prior to symptoms might be safe for recurrence of symptoms. In terms of result evaluation, could resumption of such limited activities be called cure? Treatment outcomes should be evaluated and reported relative to the golden standard of full resumption of playing at the playing level and workload before symptoms. With defects or dynamic constraints as in scenarios 5 and 6, retraining in whatever form would likely not be effective unless these factors would be adequately addressed. This can be schematically visualized. Decompensation and retraining has as ultimate criterion task effectivity. However, in scenarios 5 and 6, this retraining happens in the presence of unknown, subconsciously CNS-controlled objective functions that for the CNS also have hierarchical priority. Clearly, it is unlikely that decompensation and retraining in whatever form could normalize this situation. This concludes the model. Future HBCM lectures. This lecture presented a high-level model of how peripheral factors may cause task-specific musicians' hand dystonia in otherwise healthy musicians without CNS predispositions. In follow-up lectures, this model will be used in the analysis of cases. These cases will illustrate how the model guides case analysis. Reciprocally, the case results will substantiate the model. Scientific questions and critiques of the model may be addressed to this email address. Musicians with hand dystonia might be inclined to inquire for information regarding their own case. However, the HBCM cannot answer such requests. The HBCM performs biomechanical hand investigations for diagnostic purposes only on referral by specialized physicians who suspect complex biomechanical involvements. The procedures for contacting the HBCM in such cases are detailed at the HBCM website. Thanks for your interest.